دكتور أيمن.
Hey, Dr. Muhammad, will you start?
Yes, can you start?
السلام عليكم ورحمة الله وبركاته. Dear colleagues, بسم الله الرحمن الرحيم. الصلاة والسلام على محمد عليه الصلاة والسلام. Our topic today, me and the Dr. Muhammad al-Rashdi will see some clinical pathway, how to diagnose early and how to go for therapy early. My talk is two-part and Dr. Rashdi another two-part. My issue is how to diagnose this early and what is the lesson we will learn it from our patient experience. And Dr. Muhammad al-Rashdi, definitely he is one of our senior clinical pharmacists. They will give you the way how to manage this type of patients. First of all, TTR cardiomyopathy, clinical pathway, and the local clinical experience. In our hospital, we have around 31 cases already proved. That's why from our clinical expert, from local patient, what we gain the lesson, I will give it to you by very simple way. My name is Dr. Marcy. I am cardiology consultant. Now I working in KMC. One of our, how I go next. Table of my contents. One, what we learn from our patient, and I will make it easy. Top 10 tips and tricks from our patient red flag. Second important points, this red flag in local patient, it is equal or approximately like the red flag internationally or no, we will see now. Second important thing, I summarize around 2.5 years or maybe 3 years, what we gain from clinical educational impact challenge. I make it very simple way by tips and the tricks, and I will stop here. And then the second my talk, I will answer my tips and the tricks. What we learn from our patient, which is, I make it simple, top tips and the tricks from our patients. Second, this picture is very nice for me. If zebra take a decision to lose his strips, this exactly is the pathophysiology of the cardiac ATTR amyloid patients. So always consider this issue. So if strips of zebra is removed or try to be removed, or I can disarrangement, this is what we can say, the pathophysiology mechanism of the cardiac amyloids. Soon or later, I think everybody from cardiology point of view, you know now what is the type of heart failure, which is heart failure with reduced function, heart failure with preserved function, heart failure with mildly reduced. And I think nowadays it's become heart failure with reduced and heart failure with preserved only. Soon or later, you can see the ATTR amyloid, you can see certain entity in the coming few months, which is called heart failure ABAF, which is called heart failure amyloid BAF. From past versus present, what we think in the past and what we think in coming days or at the present. Before we consider AL amyloid is most frequent cardiac amyloid type. But nowadays, sorry to say, most of our patient, which is already diagnosed, is ATTR type, not AL type. Although the AL type is more serious and a very, very important hematological emergency and supposed to be invite our hematologist soon. Second point, we consider as a past single phenotype of restrictive cardiomyopathy pathology, which is we consider as a concentric LV thickening and low voltage ECG. But nowadays, it is not single phenotype. It is heterogeneous phenotype, diverse LVH ejection fraction and LV thickening and the ECG finding. So it is not a single phenotype, it is heterogeneous phenotype. Before, definitely we say it is a very rarely disease. Nowadays, it is not rarely at all. It is very common to see in your practice. That's why in King Abdullah Medical City and a specialized hospital now, there is specialized clinic called cardiac amyloid clinic. It is not heart failure clinic. It is purely cardiac amyloid clinic in both hospital. Before we say biopsy, always this is the only way to go to diagnosis amyloid patient. But nowadays, no. Non-invasive diagnostic is most of the time is more than enough. We are not from all our patients need biopsy whatsoever. Before in the past, mostly no therapy or a few therapy. Dr. Rajdi will say now there is a lot of therapy in your hand, which is already proved from Saudi FDA and American FDA, and they will say it definitely elegant way. What we learn from our patient, which is closely to 30 or 31, and I make it easy for you, I make it top 10 our red flag, and you can say very nicely, this red flag, it is equal or approximately equal to the international red flag or no. This I can say, if you see one of these patient profile, please try to think for this patient is ATTR amyloids. One profile, if you see patient in nephrotic range of proteinuria without diabetes, and they have LVH anatomically by echo you mean thinking from cardiac amyloids. And these 2 points is very nicely. If you see peripheral neuritis in short time of diabetic history, if your patient is young, think for Fabry disease. If your patient is middle-aged or old, especially in male, consider is cardiac amyloids. Babai sign, which is very important sign, which is rupture biceps tendon plus mild LVH, think for cardiac amyloids. Triggering finger, which is important sign, which is one of orthopedic peripheral sign, and the posture hypotension. In previously patient have hypertension, consider is this patient is cardiac amyloid. Second important thing, progressively weight loss unintentionally with patient have progressive peripheral neuritis, again, thinking of cardiac amyloid patient. If your patient have hypertension and he is already in antihypertensive therapy, and this patient need to wean from antihypertensive therapy, so patient in triple antihypertensive therapy, and then by time the patient BP is become all right or become low, so you try to wean the antihypertensive therapy, plus this patient peripheral neuritis start by motor type. Most of the time, this infiltrative pathology in the heart, and one of them is cardiac amyloids. This I can say top red flag in our patient. Number 7, ED, autonomic dysfunction, like erectile dysfunction in middle-aged patient without risk factor, plus bilateral carpal tunnel syndrome, mostly consider one of the patient is cardiac amyloids. Number 8, this very important for people, our colleagues, which is have preoperative cardiac assessment clinic. When you are in preoperative cardiac clearance clinic, think for cardiac amyloid patient if you face this type of patient profile. One profile, if patient have DDD pacemaker without any clear etiology, booked for spinal canal decompression therapy. So please consider this patient may be infiltrative cardiomyopathy, one of them of cardiac amyloids. If your patient came for cardiac clearance and they have bilateral carpal tunnel syndrome or redo carpal tunnel syndrome, and he or she positive family history of carpal tunnel thinking for this patient may be cardiac amyloids. Patients have controlled atrial fibrillation without rate control meds. Book it for bilateral knee replacement. This patient high possibility of cardiac amyloids. If your patient by his or her echo, mild LVH, a small pericardial effusion, more than grade 1 diastolic dysfunction, booked for redo rupture biceps tendon, considered as a carpal tunnel syndrome. Number 9, and this is very important home lesson, please exclude monoclonal processes with serum and urine immunofixation and the serum light chain in all patients with suspected amyloid referred for BYB scan, irrespective of the scan result. We need always to rule out AL type in order to, it is really hematological emergency. And this one of the key home message. Again, please exclude monoclonal processes with serum and urine immunofixation with serum light chain assay in all patients with suspected amyloid referred to BYB, irrespective of scan result. Always, as a general rule, do genetic test for all positive BYB scan nowadays. And this important message, in any patient, always there is essential rule now of respect. So nobody say now BYB by 1 hour scan. Nothing in medicine nowadays is called 1 hour scan. All supposed to your patient must be by essential rule of respect, meaning 3 hour BYB scan, not 1 hour. And always consider patient with grade 2 BYB, you have a lot of up to 64%. He have false positive result. So please, we need all our patients to make a scan by SPECT, not by pooling of the blood 1 hour. That's why the best practice for cardiac scan to validate, to diagnose ATTR cardiac amyloid, always think for AL amyloid first with serum-free light chain immunofixation electrophoresis. SPECT imaging to confirm myocardial retention of isotopes, meaning delayed 3 hour, not 1 hour, 3 hour imaging to minimize impact of the blood pooling. For me, this one of the key point for any cardiologist who want to go and practice amyloid clinic. Second part in my talk, clinical educational impact challenge. I make it very easy. It's called Ayman Morsi tips and tricks. What we can say, the aim of my AM tips and tricks, not testing your knowledge at all, but it is very simple hint. If you want to work in infiltrative cardiomyopathy, especially cardiac amyloids, I make it very simple way and I name it clinical educational impact challenge. I am the one which is answer the tips and the tricks. This called 12 tips and the tricks, which is concluded all our session, all our experience in the 3 years, how you get and how you diagnose early the cardiac amyloids by very simple way. By simple, take yes or no only. First question, do you agree of this concept regarding amyloidosis patient? A, the older you are, the more you are likely to have it. Although we have now in our patient, we have patient maybe 40s and 50s, but most of our patient mostly is old. Second B, if you don't think of looking for it, you are never ever diagnosed. C, so hard to make a diagnosis as you are or you are working as a solace way and assuming the horse never becomes zebra. So how you choose yes or no? Most of the time our patient is old, Always, if you are not think, you wouldn't diagnosed. So if you are working alone as a solace, you are never ever diagnosed. In order to the cardiac amyloids is multidisciplinary team diagnosis. So definitely the answer is yes. So I concluded in these slides to how you think to concept regarding cardiac amyloid patient. Second thing, in heart failure with preserved function, ATTR amyloid patient, most of our patients always clinically and physiologically and biochemically and anatomically, most of amyloidic patient is like that. Congestion and increased CVB clinically, most of the time these patients have increased LVDBs physiologically, and there is some biochemical leak like elevated natriuretic peptide biochemically. And if you make echo, mean anatomically, most of these patients have advanced diastology, E to E prime more than 14 and E prime less than 8. So most of your patients supposed to be thinking for clinically, physiologically, biochemically, and the echo finding, which is called anatomically, not echo finding alone. And the end of the day will end by PYB by this way. Lastly, not least, before when you are working in the cardiac amyloids, we are very happy to see we have patients have 555 sign in tissue Doppler imaging tracing at septal material annuli. It is pathognomonic as an early sign for diagnosis of ATT amyloid, so you're supposed to be yes or no. Before, I am very happy in my patient, which is second or third patient, when we see 555, I'm very happy in order to we diagnose another case of cardiac amyloid. But shall we consider 555 sign is early sign to diagnose cardiac amyloid? Yes or no? I will leave it for you and I will answer later on. This very important message for our colleagues which is working in echo. Don't consider 555 sign, it is an early sign. No at all. If you see 55 sign, it is very late to diagnose cardiac amyloids. So I will answer you. This very nice picture. Early functional echo anomaly, meaning tissue Doppler and strain, is perfect tool to diagnose early ATTR amyloid than morphological echo abnormality, yes or no? Meaning tissue Doppler and strain is early sign than LVH. You consider this is right or no? Definitely yes. So that diastolic failure or diastolic echo parameter like tissue Doppler imaging and strain is perfect tool to diagnose it as an early ATTR than LVH, this mean morphological echo abnormality. On the other hand, these very important points in your right side, longitudinal contractile function become impaired later in disease processes than the radial contractile function. You agree for that or no? And this again, very important practical echo finding in your echo lab. So do you consider longitudinal contractile function is impaired early or late in patient with cardiac amyloid? And this very important message. So the message is longitudinal contractile function is impaired early, not late. Early, not late. That's why it's supposed to be catch your patient early. Lastly, not least here, prevalent of ATTR cardiac amyloid most of the time is 5 to 15 years after surgery for bilateral carpal tunnel. So please, and this is my message for all our orthopedic surgeons, test please amyloid deposit at the time of your surgery is unique opportunity or a chance to diagnose ATTR amyloid in preclinical stage. And that's why in a non-specialized hospital, all our colleagues, we informing them by very gentle way, if your patient have bilateral carpal tunnel syndrome, when you make a surgery, please, if you don't mind, take some 1 minute more for what? To take amyloid deposit and send it to your lab to diagnose cardiac amyloids. This very important clinical clue for all people, surgeon working in carpal tunnel syndrome surgery, either plastic surgery, orthopedic surgery, neurosurgeon. So this message for them: if your patient have bilateral carpal tunnel syndrome surgery, please take 1 or 2 minutes, take biopsy or take amyloid deposit in order to, it is very important nowadays. Lastly, not least, atrial fibrillation is very common associated with amyloid patient. Definitely, yes. So the anticoagulation therapy is indicated according to SHAD-VASc score, and the digoxin therapy is optimal for rate control. On the other hand, the beta blocker and RAS blockade is improved survival. You agree for this concept or no? And Dr. Rajdi, they will inform you elegantly, I know, how to deal with this type of patient. And the message here, please, there is 13 type of cardiac pathology supposed to be anticoagulate this type of patient without SHAD-VASc score, and the cardiac amyloid is one of them, and the digoxin therapy is not optimally at all for rate control in these type of patients. The most accurate syndrome describes the amyloid patient. What do you think? Amyloid patient is called apical ballooning syndrome, meaning broken heart syndrome, or non-apical ballooning syndrome, which is called happy heart syndrome, or stiff heart syndrome. What you want to choose? A, B, and C. Apical ballooning, non-apical syndrome, or stiff heart syndrome. Any pathology, infiltrative pathology, most of the time will say stiff heart syndrome. Second points, we are always happy if our old hypertensive patient weaned from his antihypertensive therapy, yes or no? I think all our colleagues is become very happy, except as a cardiologist. If your patient have triple antihypertensive therapy in combination in one tablet, or 3 triple medication in 3 different tablets, and this patient is first of time after 6 months, you are weaned one of them, and then wean one of them, and then the end of the day, patient have hypertension is already cured fully. You are very happy in this type of patient? No, we are not happy at all. Why? In order to the LVH pathology changing to infiltrative pathology, that's why we consider infiltrative cardiac disease. One of them is cardiac amyloid in the top of our list. So the all cardiology is not happy at all if his patient become normotensive or hypotensive after he takes 3 or 4 antihypertensive therapy. Number 9, heart failure with preserved function in absence of hypertension, and the patient have Babai sign. You can see and concentrated about the picture. What is this picture show you? It is ruptured biceps tendon without any trauma. If you see this type of patient, it came even in your preoperative clinic assessment, patient have heart failure with preserved function, although he is no history of hypertension, came to make a clearance for him for Babai sign repair or rupture biceps tendon repair. You must suspect amyloid as one of the main differential diagnoses. So definitely yes. This very important picture and this very key slides in my lecture, especially the cardiologist, non-interventionist echo people, I think number 10 is very important. I think these are valuable picture for me. Do you have the same feeling as if you have? First picture in your left side, patient with Mickey Mouse heart. You know what you mean by Mickey Mouse heart? Mean both atrium become hugely dilated and the both ventricle is still in normal. And these patients have take ice cream, as if you see here. These patients is annoying picture for you, meaning if you see in your practice the heart of your patient is a change to become Mickey Mouse heart, this picture is annoying you or not annoying you. Second part of your patient, if you see patients in a soothing picture, he's eat ice cream and the top of ice cream sherry in top, and it is very nice picture. This called soothing picture, picture جميلة يعني. So do you happy to see soothing picture in the form of the patient have, as if you see here, you can see sherry in top picture. Last picture on your right side, it is very important for delicate cardiologist. Don't take lightly patient who have diastolic MR. So always we consider systolic MR. If you see patient have diastolic MR, this picture is very bad picture in patient with infiltrated pathology and especially cardiac amyloid. So my point, if you see patient with Mickey Mouse heart, this means the patient have end stage cardiac amyloids. If you see patients in his screening, you can see sherry in top. It is one of the soothing picture. If you see patient have diastolic matter regurg, this one of the very late sign in patient with cardiac amyloids. So we need to catch the patient early, please. Number 11, amyloidosis patient. If you see disproportionated between anatomy mean echo, you can see in echo there is LVH, and you can see electrically mean ECG, you can see low voltage in ECG, pseudo MI pattern in presence of LVH. This picture is suggested but always not diagnostic of cardiac amyloid. And this is my point. Our colleague always thinking any patient have LVH plus low voltage, it is 100% amyloid. The answer is no. It is one, I can say, as if I make it here. It's helpful. It is very suggested, but not diagnostic. Last point, aortic stenosis, and there is dilemma of aortic stenosis in presence of the amyloid. Do you think there is good relation between aortic stenosis and the ATTR cardiac amyloid? Yes or no? And I will keep the answer till the end. And thank you very much. And now Dr. Muhammad will see his first scenario, how to manage this type of patient and how you get it early therapy in this type of patient. Dr. Rajli.
Yes, Dr. Ayman, yes. Thank you, Dr. Ayman, for this comprehensive overview and a nice introduction. Can you see my slides, Dr. Ayman?
Yes, Dr. Muhammad.
Yes.
If you magnify it, it's better. Magnify the picture.
Now it's magnified. Slideshow.
Okay. Fine. Slideshow. Clear. Yes.
Okay. First of all, Assalamu alaikum wa rahmatullah wa barakatuh. Good afternoon, everyone. On behalf of Saudi Heart Association, I would like to warm welcoming you to this webinar, and it's privilege and honor to be part of this scientific webinar. I am Mohammed Al-Rashdi, cardiology clinical pharmacist at the North Specialist Hospital. Okay. Before we started, we need to understand the pathophysiology of the disease. As we know, the ATTR amyloidosis is transporter protein produced primarily in the liver. Under the normal condition, it circulates as a stable tetramer carrying the thyroxine and retinoid binding protein. TTR amyloidosis develop when this stable tetramer is become unstable, either due to genetic mutation like in hereditary ATTR or age-related instability in wild-type ATTR. The tetramer dissociation in monomers that misfolded and aggregate into the soluble amyloid fiber. This amyloid fiber may be progressively deposited in multiple organs, particularly in the heart, also in peripheral nerve, autonomic nervous system, and gastrointestinal tracts. In the heart, the amyloid deposition cause ventricular wall thickness, increase myocardial stiffness, impaired diastolic feeling, conduction abnormality, and eventually heart failure. Since ATTR cardiomyopathy is an infiltrative rather than inflammatory disease, the patient often present to the clinic with preserved ejection fraction. The key concept in the pathophysiology of the disease is the balancing between amyloid deposition and clearance. In healthy individual, the abnormal protein are effectively cleared. However, in ATTR amyloid, the production misfolding ATTR exceed the body clearance capacity, leading to progressive amyloid accumulation and ultimate irreversible organ dysfunction. Despite of recent advance in the diagnosis and the treatment, ATTR cardiomyopathy is the disease remain underdiagnosed and frequently misdiagnosed, resulting in delayed diagnosis and missed opportunities for early treatment, such as heart failure, neuropathy, carpal tunnel syndrome, and gastrointestinal manifestation. Consequently, the average diagnosis delayed in 3 to 8 years, allowing progressive amyloid deposition and irreversible organ damage. The study also showed up to 44% of the patients are initially misdiagnosed, and nearly half of them there are consult 3 or more physicians to receiving the correct diagnosis. Finally, limited access to ATTR cardiomyopathy specialist or center remain another barrier, with the 1 in 5 patients traveling more than 2 hours for expert evaluation, emphasizing the need for greater disease awareness and earlier referral. So, the progressive disease without timely diagnosis and treatment, the disease progresses continuously from early heart failure and arrhythmia to restrictive cardiomyopathy, characterized by the recurrent heart failure hospitalization and ultimately to the end-stage heart failure or advanced heart failure. Historically, the median survival after diagnosis was only about 2 to 6 months. Treatment delayed lead to irreversible loss of quality of life and disease progression. Now just we'll look for guideline and new direction in the therapy and paradigm shift. Actually, before 2019, the management was largely based on supportive care with no disease-modifying therapy available. Hence, the traditional just only watch and wait approach. The first major breakthrough came in 2019 with approval tafamidis. It was the first therapy showing improved survival and reduced heart failure or cardiovascular hospitalization. This was followed by acoramidis in 2024, expanding the class of TTR stabilizer, and fitusiran in 2025, the first TTR silencer therapy approved for ATTR cardiomyopathy, providing another effective disease-modifying therapy. In the past 6 years, ATTR cardiomyopathy moved from fatal diagnosis with no option to the disease with 3 approved therapy and the guideline mandate to treat early. Now, we'll overview the next few slides, or we'll summarize the key findings from the 3 landmark trials that have fundamentally changed the management of ATTR cardiomyopathy. We'll start with ATTR Act, which established tafamidis as the first disease-modifying therapy. Then we'll followed by attribute cardiomyopathy, which demonstrates the efficacy of acoramidis, the next generation of TTR stabilizer. Lastly, we'll overview and highlight Helios B, which introduced fitusiran, the first RNA interference therapy approved for ATTR cardiomyopathy. Before we reviewing the efficacy results, it's important to briefly look at the baseline characteristic of patients enrolled in this trial. Overall, the study population were broadly comparable. The mean age range from approximately 74 to 77 years, reflecting the elderly population typically affected by ATTR cardiomyopathy. The majority of patients had wild-type ATTR, accounting for about a range from 76% up to 90% of participants, while the variant wild-type or hereditary type, it's range from 10% up to 24%. Regarding the disease severity, most of patients were in NYAHA class 2 with the similar proportional in class 3. Importantly, patients with advanced heart failure were excluded from the trial, highlighting that the trial primarily evaluated the patient with mild to moderate symptomatic disease. Having reviewing now the evidence of disease-modifying therapy, let's now focus on first therapeutic class TTR stabilizer. In this class included tafamidis and acoramidis, both of which target the disease at the earlier step by stabilizing the transthetene tetramer by preventing tetramer dissociation into the unstable monomer. They reduce amyloid fiber formation and slow disease progression. We will begin with ATTR-ACT trial. This was multi-center randomized double-blind placebo-controlled trial that enrolled around 400 patients with either wild type or hereditary type. The eligible patients have symptomatic heart failure or ATTR symptoms with the evidence of cardiac involvement, including increased ventricular wall thickness greater than 12 millimeter, history of heart failure, hospitalization, or diuretic need, with elevated end-terminal proBNP to be more than 600, as well as the 6-minute walk distance more than 10 meters with preserved ejection fraction, kidney function, and the ejection fraction more than 25. The patients were randomized into 2:1:2 ratio to receive tafamidis 80 milligram, tafamidis 20 milligram, or placebo for 30 months. For the primary analysis of 2 tafamidis dose group were both to evaluate the primary endpoint, composite all cause of mortality and frequency of cardiovascular related hospitalization. The result for mortality of tafamidis significantly reduced the all cause of mortality compared with the placebo by 26.5% in tafamidis group when we compared with the 42.9% in placebo group with the hazard ratio of 0.7 with 30% relative risk reduction, because the tafamidis is a stabilizer the transthetene tetramer rather than removing existing amyloid deposit. It's clinically benefit accumulation over the time. There is why we don't see an immediate difference on the survival curve. The treatment slow ongoing disease progression, making the early diagnosis and sustained therapy essential. What's about the secondary endpoint for 6 minutes or functional capacity and quality of life? For 6-minute walk distance test, as we expected, the walking distance declined over the time in both groups because ATTR cardiomyopathy is a progressive disease. However, the decline was significantly slower in tafamidis at the 30-month. Patient treated with tafamidis walking approximately 80 meters further than those receiving placebo. On the right side, you will see the Kansas City Cardiomyopathy Questionnaire score, the validated measurement for heart failure or related quality of life. Again, both groups experience deterioration over the time, but the patient who receiving tafamidis had significantly smaller decline with approximately 15-point difference when compared with the placebo at the 30 month. The second landmark trial, it was ATTR cardiomyopathy. It's phase 3 randomized double-blind placebo-controlled trial that enrolled around 600 patients with either wild type or variant type ATTR. Patients also include the patient with the NIAHA class 2 to 3. It's almost the same inclusion criteria for ATTR Act, and the light chain also excluded from the trial. The primary endpoint of ATTR attribute cardiomyopathy is to include all cause of mortality, cardiovascular-related hospitalization, change in NT-proBNP, and change in 6-minute walking distance. On the left side, the Kaplan-Meier curve is showing time to all-cause mortality or first cardiovascular hospitalization over the 30 months. The patient treated with acoramidis experiences significant fewer events than those receiving placebo, with a hazard ratio of 0.56, corresponding to 44% of relative risk reduction. On the right, acoramidis also reduced cardiovascular mortality from 21.3% in the placebo group to 14.9% in acoramidis group. This represents a 30% relative risk reduction and 6.4 absolute risk reduction. Now we'll come to the second class. It's TTR gene silencer. Fitusiran, unlike TTR stabilizer, which prevent TTR dissociation, the gene silencer work upstream by reducing the production of transthyretin in the liver. Let's now turn to HELIOS-B trial. This is the landmark first 3 study evaluating fitusiran, and we'll consider also the first RNA interference therapy approved for the patient with ATTR cardiomyopathy. This was the randomized, double-blind, placebo-controlled trial enrolled 655 patients with either wild type or hereditary type and symptomatic heart failure. All of this 3 trials, mostly the same inclusion criteria. The patients were randomized into 1-to-1 ratio to receive either fitusiran 25 administered subcutaneously every 3 months or placebo. One unique feature of the HELIOS-B is that approximately 40% of patients were already receiving tafamidis at the baseline. This allowed investigator to evaluate the benefit of fitusiran both as monotherapy or when added to standard therapy, making the result highly relevant to the current clinical practice. The primary endpoint was the composite of all cause of mortality and recurrent cardiovascular event, while importantly the secondary endpoint include functional capacity measured by 6-minute walk distance, quality of life using the Kansas City questionnaire score or NIAHA class function, and all cause of mortality. The result of this trial, this study was demonstrated that fitusiran provides sustained survival benefit and significant reducing of all cause of mortality and cardiovascular mortality compared with the placebo over the 42-month of follow-up. On the left side, as showing the fitusiran reducing the risk of all cause of mortality by 36 with a hazard ratio of 0.64%. Similarly, on the right side, fitusiran reduced cardiovascular mortality by 33% with a hazard ratio of 0.67. On the left, the fitusiran reduced all cause of mortality by 36 with the hazard ratio of 0.64 and statistically significant. Similarly, on the right, fitusiran reduced cardiovascular mortality by 33%. One of the key strengths of HELIOS-B trial is that evaluate the effect of fitusiran across the clinically relevant patient subgroup. In the overall population, fitusiran reduced composite of cardiovascular mortality and recurrent cardiovascular event by 28% with the hazard ratio of 0.7, demonstrating the significant clinical significance. When we looked at patients receiving fitusiran as monotherapy, the benefit was even greater with 32 relative risk reduction and the hazard ratio of 0.6. An important subgroup included the patient who already receiving tafamidis at the baseline. In this subgroup, the hazard ratio also favored fitusiran. However, this result don't show or don't reach statistical significance. For secondary endpoint, compared with the placebo, patient who receiving fitusiran experiencing significant smaller decline in the 6-minute walking distance, including better preservation of functional capacity, similarly quality of life assessed using Kansas City cardiomyopathy questionnaire score decline much less in fitusiran group, reflecting better symptoms. For also secondary endpoint for heart failure hospitalization or recurrent outpatient worsening heart failure, compared with the placebo, fitusiran reduce the risk of first outpatient worsening heart failure even by 27% and recurrent worsening heart failure even by 34%. And thank you for your attention. This is the last slide of first part of my presentation. Now we'll back for Dr. Ayman Mursi to continue the second part of this event and webinar. Dr. Ayman, floor is for you. Dr. Ayman, are you hearing me?
Yes, yes. Thank you, Dr. Muhammad. Very nice presentation, and you are helping me to answer my tips and tricks. My second part, the how to answer the clinical educational impact challenge by very simple way. Do you remember when we say how to judge the patient? Definitely, your patient, most of our patient is little bit old and are more likely to have. And definitely, if you are not sync for diagnosis, you are never ever diagnosed. And alwaysly, we are panel plan discussion supposed to be treated by neurology, gastroenterology, ophthalmology, definitely clinical pharmacist. So if you think you are working as a solace, you are never ever diagnose these type of patients. So the answer definitely yes. Second thing, this classically, our patient, when you see any patient, clinically is increased CVB and increase LVDB physiologically. And if you see biochemically elevated natriuretic peptide, and if you see by echo, E to A prime more than 14, and the E prime less than 8, this definitely all patients of heart failure with preserved function, most of the time, this exactly clinically and physiologically and biochemically and anatomically like that. So if you see this profile of patient, think of cardiac amyloids. Second thing is if you see 555 sign in tissue Doppler tracing at the septal mitral annulus, is pathognomonic as an early sign for diagnosis of ATTR amyloids. So the answer definitely is big no. So don't consider and don't wait your patient till reach Mickey Mouse heart or 555 sign. So if you get this type of patient profile, this patient is very late sign, and I think they are not good benefit to start as a medication. This my concern alwaysly. Reduce tissue Doppler velocity. It is very, can say here, very late sign. As 555 sign, it is very, very late sign. We can say it is mean advanced cardiac amyloids. And alwaysly see if you can see decreased tissue velocity and isovolemic contraction and relaxation time, IVCT and IVRT, are increased and the ejection time is decreased. All these findings of the cardiac amyloid, it is very advanced pathology. So don't wait at all till we'll see 555 sign or decrease the tissue velocity, isovolemic contraction, and relaxation time in order to all both of these tissue Doppler parameter is all of this very late sign. And this very nice issue alwaysly. Alwaysly you consider TDI and the strain is very good sign to diagnose the patient early. So don't wait even till LVH coming. That's why the general rule, early functional echo abnormality, mean tissue Doppler and the strain is very perfect tool to diagnose early sign of cardiac amyloid than ATTR morphologically mean Mickey Mouse heart or LVH. That's why I make it very important statement here. I make it true, false, true, false. Most of our patient is one of the cause of HBF. However, it underestimates the degree of systolic impairment that occur during amyloid fiber deposition. The cardiac amyloid position, the cardiac amyloid patient is kill the diastolic function before systology. Amyloid deposition without any clear pathophysiology. Why alwaysly the deposition of amyloid occurs from base to apex and not vice versa. That's why share on top sign, one of the clue sign in the patient of cardiac amyloid. Nobody knows why alwaysly the amyloid deposition is starting from the base of the heart to the apex, and the apex most of the time is preserved. Again, alwaysly we are mentioned for echo people, longitudinal contractile myocardial fiber are alwaysly predominant in not endocardia, where the radial contractile fiber mostly isolated and positioned in the mid wall. That's why longitudinal contractile function is impaired early, not late, early. So in my point here, I make it late. Late mean false. So longitudinal contractile function alwaysly impaired early than the radial contractile function. This is my message for our echo colleagues. Most of the time, the longitudinal contractile function is alwaysly impaired early than the radial contractile function. That's why I make it false. Why this pathology is, in order to longitudinal contractile myocardial is always predominant, situated in the endocardium, but the radial contractile fiber are always positioned in the mid wall. This very important point, any people want to diagnose by echo lab people. This is my picture. Always without any clear pathology, without any clear theory, why the amyloid deposition start from the base and the apex, and most of the time the apex is preserved. That's why called cherry in top. And always started from endo to epicardium, not epi to endo, from endo to epicardium. Again and again, presence of the patient of the bicarpal tunnel syndrome, most of the time it is came 5 to 15 years early. That's why always we make it this way. in any surgeon working in carpal tunnel people, always before you start, make it very simple test. Apart to take biopsy, no, make it biochemical marker. So all people go for carpal tunnel, especially bilateral carpal tunnel syndrome. Please inform your colleague to make two important biochemical markers, troponemia and NT-proBNP. If the troponemia or TRAP-T less than 13 and NB-proBNP less than age of your patient, in order to most of our patient is little bit old. So please stop investigation, and also no need to take biopsy during your surgery. On the other hand, if your patient before he go to OR, the troponemia or TNT more than 13 and the NT-proBNP more increase than depending cutoff due to his aging, this is a patient which is supposed to be screened for cardiac amyloid. And my message is very nice in your last right side here. Even your patient, when you stop to investigate, reassess every 5 years or before if new red flag appear. This very important key slides. So the surgeon which is working in carpal tunnel, we need to put this one in their consideration. Before you go to ER, like make CBC, chemistry, serum potassium, and then. So please make a troponemia and NB-proBNP. If troponemia more than 13 and NT is more than his aging, please screen for cardiac amyloid. In this type of profile of the patient, take biopsy during your surgery. This gives you hint how to get the patient early. That's why always we need to catch ATTR amyloid cascade. Don't wait your patient till have diastolic dysfunction in disease parameter. Don't wait till he have elevated natriuretic peptide biochemically. Don't wait his ECG become low voltage. Don't wait when becomes systolic dysfunction. As if you can see here in the top of the row, you can see the symptoms, low voltage, systology, diastology is very, very late sign. Second important thing here, you can see very nicely and very elegantly. The patient of TTR cardiac amyloid, he have 89% have orthopedic issue, orthopedic symptom, orthopedic sign, and 11% only have no orthopedic sign. So what's our main home lesson for any cardiologist working in TTR cardiac amyloid field? Always orthopedic issue or orthopedic sign is one of the key signs in order to most of them appear before cardiac involvement, maybe 10 years. That's why supposed to be all orthopedic tissue, especially bilateral carpal tunnel, trigger finger, biceps tendon rupture, Babai sign, lumbar spine stenosis surgery, and then this is the way to go. You can say, I like these slides. This first manifestation of the disease of the patient of the carpal tunnel, you can see very nicely the first presentation of patient of ATTR, 48% in your left side have carpal tunnel syndrome. So the first manifestation of patient of ATTR cardiomyopathy, around 50%, 48% have carpal tunnel syndrome. And you can see nicely, only 14% have neuropathy and the 14% have cardiac involvement. In your right side, you can see very nicely again, associated symptom in the patient who have carpal tunnel surgery release, 40% have no any symptoms at all, except the carpal tunnel syndrome. 10% only GI symptoms, have 20% cardiac symptoms. So the carpal tunnel syndrome, one of the key for patient profile in order to, it is very, very early sign. Lastly, not least, as if AFib is commonly associated with cardiac amyloid. It is true. And the anticoagulation therapy is indicated according to Schott-Vasquez score. The answer is no. So any patient have amyloid with AFib, please don't follow Schott score at all. Like a lot of pathology, like rheumatic heart disease, for example. Rheumatic heart disease AFib, please don't follow Schott score. Make it tachycardia-induced myopathy, AFib, cytotoxic AFib, apical ballooning syndrome AFib. All these one we are not following Schott score, and these patients supposed to be by class 1 is anticoagulate them. On the other hand, digoxin therapy, as if Dr. Muhammad will say soon, it is not an optimal rate control medication, and I leave it for him why. On the other hand, the beta blocker most of the time and the RAS blockade is never ever improve survival. That's why the AFib is common, yes. Please don't follow Schott score in these types supposed to be anticoagulate them. Digoxin please not used as a rate control, and the beta blocker even and RAS blockade most of the time is not improve survival like any patient of heart failure. You can see very nicely here the arrhythmia, which is very common in cardiac amyloid. In early stage, you can see around 30% of the patient AFib, and the patient with late stage of cardiac amyloid, you can reach the AFib incidence reach up to 70%. And the very nicely here, oral anticoagulation therapy is recommended in all patients with atrial fibrillation and hypertrophic myopathy or cardiac amyloidosis, regardless of Schott score, to prevent ischemic stroke and thromboembolism. So please don't follow Schott score in this type of patient profile. And the classical here, it is European Society of Heart 2024, ACC, and European Heart Journal, even class 1 evidence B. And this is my message again, and Dr. Muhammad definitely will inform you. Please don't say TE cardioversion in cardiac amyloid patient in order to, I can say very openly from our experience in our patient, 28% cancel due to thrombosis, even patient in sinus rhythm. And the 14% have a lot of complication if you make cardioversion, especially VTVF, right? So the cardioversion in cardiac amyloid patient, please put it in your cautiously, and the TE is recommended even if patient in anticoagulation therapy and even patient on sinus rhythm. Why in patient in cardiac amyloid and the patient is not atrial fibrillation and the very common TC to see very commonly left atrial appendage thrombus due to very nice term, and I like it, which go left atrial dissociation, which is very important, atrial thrombus, which is occurred during sinus rhythm in cardiac amyloid patient, which is evidenced by atrial electromechanical dissociation. And I like as a cardiologist this term, atrial electromechanical dissociation. This is the main pathology in this type of patient, which is have patient on sinus rhythm, and you can see very frequently left atrial appendage clot. That's why try to not use cardioversion in this type of patient. Definitely, as if I informed you before, the classical syndrome in amyloid patient is a stiff heart syndrome, not broken heart syndrome, and not happy heart syndrome. Alwaysly, all the family medicine physician and all general medicine colleagues alwaysly become very happy if his patient is weaned from all hypertensive patient, but we are, as a cardiology, we are not happy at all. In order to most of these patients, the pathology changes fully. It changes fully from LVH to issue of infiltrative pathology. Alwaysly think if patient have high heart failure with preserved function and they go in your preoperative assessment clinic with Babai sign mean rupture biceps tendon, you must be suspected cardiac amyloid, especially one of the main differential diagnosis, especially amyloid patient. This very nicely, I inform you, this annoying picture in your left side, so don't wait till your patient become Mickey Mouse heart, huge post atrium, post ventricle is fine, but I think cherry in top is soothing picture. It is beautiful picture, But Mickey Mouse heart, it is very badly annoying picture. And again, in your right side, the histology of matter regurg is very, very late sign in patient with infiltrative pathology, especially cardiac amyloid patient. Shall will see this type of pathology, Mickey Mouse heart, diastolic MR, supposed to be not to start the medication for them. I don't know. I don't know. We'll see. Most of the time, we are always happy to see patients who have LVH anatomically by echo, and always you can see low voltage, which is very fine, definitely. But I make it easy here, helpful suggested, but please don't consider 100% diagnostic. Why? In order you can see there is discordance between voltage and wall thickening in male and the female. Definitely sensitivity is very high in male and 91, but you can see here very nicely specificity is very low. So as if I mentioned here helpful, suggested, but not diagnostic. Why? In order to the sensitivity is fine, but the specificity is low. That's why I make it some important thing. Most of new device, this important for echo people working in amyloid field. Most of our new echo device have harmonic mode. That's why, which give false sensation by sparkling sign, which is important sign for infiltrative disease. So my message and my important lesson for them, please watch the echo machines to harmonic mode off. Why? In order to, if you keep harmonic mode on, it is give false sensation. Again, apical four-chamber view is not typical to measure the free wall thickening. The typical view to measure the free wall thickening is subcostal view. Again and again, and this very nice picture. If you see patient have left ventricular hypertrophy, and there is hypertrophy in the septum even, and the hypertrophy in the papillary muscle. Most of this patient is infiltrative disease. One of them is cardiac amyloid. The hypertensive heart disease not lead to papillary muscle hypertrophied at all, not lead to septum hypertrophied, not lipictinial muscle even hypertrophied. So the hypertrophy in the popliteal muscle and papillary muscle and the LVH, mostly this patient, it is not simple LVH. That's why I can say, if you see all of them LVH and septum is enlarged, the intra-atrial septum is hypertrophy, ventricular septum is hypertrophy, both papillary muscle, anterolateral and postmedial papillary is hypertrophied. So mostly thinking for this patient have infiltrative lung, infiltrative disease. One of them is cardiac amyloids. Lastly, not least, do you think there is good relation between aortic stenosis and the ATTR amyloids? Definitely yes. How to make it simple here? This very nice publication, it is Middle Age publication. All of this one, I can say Wolf, it is in the closest of aortic stenosis. Mean we make it very simple score, which is called rising score, which is make awareness in clinical practice. And you can see very nice picture here. You can see Wolf in between the chap. So this exactly how the aortic stenosis act in case of cardiac amyloids, as if you are see Wolf in the chap. So that's why this score is very nice, which is called RISE score. And again, this is very important for cardiologists working in amyloid field. So rising score are remodeling, mean LVH and the diastolic dysfunction indices parameter impairment, age from A, eye injury means there is tribunemia, especially tribunin T, S systemic mean carpal tunnel syndrome, electrically mean low voltage or right bundle branch block with low voltage. You can see in your right side the score, if the patient have carpal tunnel syndrome alone, the point is 3. Right bundle is 2, age more than 80 is 1, and the tribunemia more than 20 is 1, and the A ratio more than 1.41. And in the your right side here is a point and the specificity and sensitivity. You can see if your patient have more than 6 points, have a specificity is 100%, believe it or not. If patient have 5 points, it is specificity is 98.9, more than 4, 95, more than 3 point is 83, more than 2, 52.1, and if patient have more than 1, you have 16.6% of specificity. So try to use this rising score in order to give you hint and is simplified how to go with cardiac amyloids. I stop here and thank you very much.
Thank you, Dr. Ayman. Really, you make the second part of my presentation to be easy.
Perfect. Thank you, Dr. Mohammed.
You see my slide, Dr. Ayman?
Yes, Dr. Mohammed.
Okay. Okay, as explained with Dr. Ayman, the patient with ATTR amyloidosis, it has multiple comorbidities and need to optimizing all of these comorbidities and therapy. Despite of advanced disease-modifying therapy has transformed the treatment landscape of ATTR amyloidosis. However, despite of this remarkable advance, our patient continue to experience heart failure symptoms, arrhythmia, functional limitation. This is the rise and important questions. How do our patient optimize, how we can optimize the day-to-day care of patient living with ATTR amyloidosis? The amyloidosis is the progressive multi-system disease requiring multidisciplinary approach to optimize the patient outcome, while the cardiologist leading to management of heart failure, arrhythmia, conductional abnormality. However, the collaboration with other teams is very important and crucial for neurologists also play the critical role in evaluating peripheral and autonomic neuropathy, particularly in hereditary ATTR amyloidosis. The primary care physician are also often the first to encounter early manifestation such as bilateral carpal tunnel syndrome, lumbar spinal stenosis, unexplained heart failure with the preserved ejection fraction, or peripheral neuropathy. Their awareness is essential for reducing the diagnostic delay, which remain the major challenge in ATTR amyloidosis. Also, clinical pharmacists contribute by optimizing supporting pharmacotherapy, adjusting the medication according to the patient profile, minimizing drug interaction, monitoring adverse effect, and supporting access and adherence to disease modifying therapy. Actually, now we'll cover the ATTR patient with cardiac manifestation. We'll start with the cardiomyopathy management and symptoms. The supportive management can be summarized into 4 key principles. First, optimizing the volume status with the careful diuresis. Second, manage arrhythmia with appropriate. And third, recognize that the conventional heart failure therapy are frequently poorly tolerated and should be individualized. And finally, identify the patient who may benefit from the advanced therapy, such as heart transplantation, may be considered in selected case. The cornerstone of heart failure patients in management of ATTR cardiomyopathy is the careful volume control. Loop diuretics remain the first-line therapy to relieve congestion while maintaining the adequate preload and organ perfusion, monitoring weight and hydric balance, blood pressure and renal function. Trosemide is preferred for potency and bioavailability. High dose of nephrotic syndrome, the intravenous if needed in advanced stage disease. The mineralocorticoid receptor antagonist, like spironolactone or ibrilinone, can be added to enhance diuresis and reduce hypokalemia with the close monitoring of renal function and blood pressure. In contrast, the conventional guideline-directed medical therapy for HFrEF patient, including ACE inhibitor, ARBs, ARNI, and beta blocker are generally poorly tolerated due to restrictive physiology and autonomic dysfunction, hypotension, and conduction disease. Therefore, their use should be individualized rather than routine and standard therapy. And regarding SGLT2 inhibitor, there is, according to the observational data, demonstrate the good tolerability and associated with the lower mortality. However, the heart failure hospitalization and reduced diuretic requirements. The symptoms, diuretic, including aldosterone antagonist, caution to be used, tolerated, but no proven benefit. Patient may also develop diuretic resistance. Blood pressure treatment, avoid ACE inhibitor, ARBs, or beta blocker groups, poorly tolerated and can be lead to further decrease for stroke volume and hypotension. Calcium channel blocker generally avoided in all patients, may be bind to amyloid fiber promoting hyperphysiological effect. Digoxin avoid, may bind to amyloid fiber and cause rhythm disturbance or sudden cardiac death. Anticoagulation, the risk for intracardiac thrombus can be lowered with anticoagulation therapy. Comprehensive clinical assessment of high risk future should be inform the decision to prescribe an anticoagulant, and the anticoagulation in patients with atrial fibrillation should be regardless of its FAST score. Inotropic support, minimal or no proven benefit at all. The pacemaker, caution, procedure can result in induced stroke of volume and right ventricular output. Cardioversion lack of data conferring survival benefit, and careful or risk or benefit analysis is required. Vagal maneuver, generally avoided, can lead to decreased cardiac output and hypotension. For patients with advanced heart failure, there is no single marker of advanced heart failure in ATTR cardiomyopathy. Instead, we look for combination of red flag, which include recurrent heart failure hospitalization, persistence, NIAHA class 3 or 2-4 symptoms, worsening functional capacity, escalating or needed diuretic requirement or increase in diuretic requirement, end organ dysfunction, hypotension, and refractory ventricular arrhythmia. Recognize of this future early should prompt referral to advanced heart failure and amyloid centers. Once the advanced heart failure is identified, the patient should be evaluated for advanced treatment option. Heart failure transplantation remain preferred option for selected patient, although the significant or due to significant extracardiac involvement like in polyneuropathy may limit eligibility, while the mechanical circulatory support may serve as bridge in selected case. For patients who are not candidate for advanced therapy, early integration of palliative care is essential to optimize symptoms control and improve quality of life. Management of ATTR amyloidosis with atrial fibrillation or atrial flutter, highly thrombotic risk. The intracardiac thrombus occur in up to 33% of the patient, even with chronic anticoagulation. Anticoagulation or anticoagulant in all patients should be started regardless of a FAST score. The anticoagulation is class 1 recommendation in this patient. TTE before every cardioversion, perform TTE before every cardioversion, irrespective of anticoagulation duration to exclude left ventricular appendage thrombus. It shows of anticoagulation, limited randomized clinical trial have shown comparing DUAC or warfarin in ATTR amyloidosis patient. DUAC are generally preferred in current clinical practice because of their use and favorable real-world experience. For management for rate or rhythm control, the guideline it's preferred amiodarone in the early of the disease. Rhythm control be useful in early stage. Similar survival under rhythm or rate control. The antiarrhythmic agent of choice is amiodarone. For rate control, for a patient with atrial fibrillation, the risk of bradyarrhythmia and hypotension is high. Aggravate heart failure due to negative inotropic and chronotropic effect. So the beta blocker is not preferred as first option in patients with especially in patient with ATTR. Firstly, we started with rate control amiodarone. If patient is still not controlled or not improved with amiodarone, maybe we add small dose of beta blocker. For digoxin, possible risk of digitalis toxicity beyond to binding to the amyloid fiber, avoid use. If you use it, start with the low dose and with the caution and monitoring regularly of digoxin level after 5 to 7 days. Needed for monitoring of serum digoxin level and renal function electrolyte every 1 to 2 weeks in the first month, then monthly for the 3 months. Needed for monthly monitoring thyroid function, regularly assess the need to continue digoxin. For other symptoms, for patient with other manifestation, for example, neuropathic pain, the supportive care of ATTR amyloidosis extend beyond and require symptoms-directed approach. Neuropathic pain is typically managed with gabapentin or SNRI, while the gastrointestinal manifestation is treated with dietary modification or targeted disease based on the underlying manifestation. For orthostatic hypotension, should be managed with both non-pharmacological or mainly pharmacological agents such as amiodarone, amiodarone, or fludrocortisone. The European Society of Cardiology positioned the diagnostic for monitoring for patients with ATTR. Actually, they divide the patient into two groups: ATTR amyloidosis with the cardiomyopathy patient. This patient with symptomatic ATTR every 6 months ECG and in-terminal proBNP, troponin, and neurological evaluation in hereditary type ATTR, and optional for 6-minute walking distance in patient with asymptomatic ATTR, the every 12-month echo or cardiac MRI, 24-hour Holter ECG, ophthalmological evaluation in hereditary ATTR. The critical point in biomarker integration, the single elevated in ATTR, pro-PMP or troponin, meaning nothing in isolation of ATTR cardiomyopathy. This patient always have elevated biomarker. What we are tracking is the trajectory arising in ATTR pro-BNP over the 3 consecutive measurements, despite optimized therapy, signals of disease progression or decompensation for some asymptomatic ATTR genetic carrier, annual ECG biomarker Holter every 2 years, scintigraphy and cardiac every 3 months. If any test is abnormal, start surveillance approximately 10 years before expected age of onset in the family. The European Society also, for cardiac complication, give 4 key messages. The message one, first message is heart failure control in heart failure patient. Start with the control fluid with the diuresis, avoid use of beta blocker, ACE inhibitor, ARBs, and LFAT not suitable for most of patient, heart transplantation for selected patient. The second message for thromboembolism, high risk and common, the anticoagulation in AFib, consider anticoagulation even in patients with sinus rhythm in selected high-risk cases, independent of CHAD FACIT score. Message 3, ICD used only for secondary prevention. There is no evidence to be used for primary prevention of sudden cardiac death. TAVI patient, the TAVI improve outcome in amyloid aortic stenosis. Don't deny the patient with the valve intervention because they also have amyloid ATTR cardiomyopathy in up to 15% in TAVI candidate. This is the statement for diagnosis and treatment of cardiomyopathy is published in the guidelines. This is the last slide. Thank you for your attention, and thank you for Dr. Ayman for joining us. And also we'll extend thanks for Swiss Biofarm for sponsoring of this meeting.
Thank you very much, Dr. Muhammad. Very elegant presentation. And we'll open the discussion in QA boxes, or you can open the discussion for anybody want any point supposed to be discussed. Any question from audience, especially cardiologists, especially non-interventionists, especially heart failure colleagues? No questions? There is one. Assalamu alaikum. No, this personally message in QA boxes. Some colleagues say they need my personal phone. Fine, okay, no problem at all. Anybody want to something importantly about amyloid patients? Clinical pharmacologist, apart from Dr. Muhammad, you want to ask Dr. Rashdi for anything for you? Somebody mentioned, I ask, why diagnosis rate is still low? Very common points. Is still low in order to, we are not following the how to diagnosis. So the important thing, don't working alone, as if I mentioned, if you work as a solace and you feel you can diagnose. No, it is multidisciplinary diagnosis, especially from neurology, cardiology, and other specialty. And always share your colleagues, especially the surgeon, how we get a lot of patient number in our institute by very good sharing with surgeon, with gastroenterologist, with the head of department of neurologist. Personally, thanks for him. And there is one good surgeon nowadays working in the only field of carpal tunnel, and they make good relation between me and her. This Dr. Rauda, which is very nice. I thanks for her. So any patient with carpal tunnel go to surgeon, she will stop the surgeon till will inform us. So we need multidisciplinary team, honestly, to diagnose these type of patients. Somebody tell here, thank you, Dr. Marcy. It is very nice presentation. What is the role of combination therapy? This is Dr. Rajdi. Any role of combination therapy now, they are meaning stabilizer and silence in the same patient, Dr. Rajdi?
Yes, Dr. Ayman, for this question, this very important questions. Actually, the guideline don't recommend to use the combination therapy, and also the costly of the medication, it's high, and there is no evidence supporting this combination therapy in ATTR amyloidosis.
Very good, the short answer, and very nicely. No any guideline till now. They say combination therapy, but the important thing, maybe future say something apart from our answer now. But till now, no any rule as of Dr. Rajdi mentioned. Anybody want to say something more? I read it now. QA boxes. Another. How we prevent middle age from heart failure by lifestyle and nutritional plan. I'm not getting the points here. How we prevent middle age from heart failure by lifestyle and nutritional plan. This apart from our presentation, but I'm definitely the lifestyle is important. 3 tight is important: tight glycemic control, tight blood pressure control, and tight lipid control. One of the important key for middle-aged patient to prevent heart failure style, and definitely there is nutritional plan, definitely. Somebody say, Dr. Muhammad, Dr. Ayman, nice lecture. Are there is any proved diet intervention that can help to treat this patient with adjuvant therapy? Dr. Muhammad, do you have any concern about diet therapy with our pharmacological therapy can prevent or can delay cardiac amyloid patient?
Actually, no evidence support this. Only the dietary support for gastrointestinal symptoms, just for supportive of care, added on pharmacological therapy. For purely patient or patient with ATTR amyloidosis, still we didn't have any evidence to support, because the pathophysiology of disease itself.
Very nicely, and a very good answer. Some colleagues, they are not mentioned name. Dr. Muhammad, what your comment in eplonizumab use in ATTR?
The Ibriztan, it was approved and FDA approved and European approved for patient with mixed phenotype, polyneuropathy and cardiac polyneuropathy and cardiac ATTR. It's not proven for patient with ATTR cardiac amyloidosis alone without the polyneuropathy.
So he mentioned, Dr. Rajdi, very important point in order to, it is very common question. This medication is very nice medication, by the way, but it is not proved till now for pure cardiomyopathy ATTR type, but for mixed type, that's fine. Another point, it is true, Dr. Marcy, that cardiac amyloid could be missed by echo. Electrical activity is more important, and even if negative, need cardiac biopsy. Actually, I think the clues for cardiac echo now, if you concentrated about the echo parameter, especially diastology, it is important to become easy, not missed, but definitely cardiac amyloid, if you are not thinking when you are make diagnosis in echo, easy to be missed. But always I mentioned some important echo clue. Diastology is important than cytology. Second thing, longitudinal strain fiber function is important early than radial. Second thing, 555 is not an early sign. Second and lastly, don't wait your patient to become anatomically by echo as a Mickey Mouse heart. Cherry top is one of the important sign, but it can easy to be missed, definitely right. Somebody mentioned is there is expected preventive therapy for hereditary ATTR, Dr. Muhammad?
For hereditary preventive therapy, no. There is in the guideline, and there is no evidence to support preventive therapy for hereditary type, what I remember.
So till now, no anything expected preventive therapy. Anything different between two stabilizer? Any difference between tafamidis and acoramidis? Anything magic difference for the way to be stabilize the amyloid fiber, Dr. Muhammad?
Actually, the acoramidis is introduced as potent ATTR stabilizer in the trial. Acrobat cardiomyopathy trial was showing 99% of stabilizer for misfolded fibrin. This is the only advantage of ATTR. The acoramidis over the tafamidis, but almost for primary and secondary endpoint almost the same.
Perfectly. Dr.
Acoramidis, it's still not approved in Saudi Arabia, only approved in our kingdom. It's the tafamidis, and acoramidis is still, I think, under the process.
Excellent, perfect. This important message for our colleagues, which is following me. Acoramidis is very nice medications, but till now it is not approved from Saudi FDA. Soon they will prove it. Dr. Halim, when to change stabilizer to silence? How to choose the initial disease modified agent, Dr. Rajdi?
Actually, the guideline didn't give any preference to start with which one, but only they focus on the cost, because the stabilizer and silencer, the silencer, it's very costly medication. It's one vial per year, maybe all the cost around 500,000 riyals when we compare it with the stabilizer. So the guidelines go with the stabilizer first, okay, and the patient of still going with the progressive, go with silencer, mainly due to the cost issue.
Okay, nicely. So when Dr. Muhammad, you see one patient now proved by PYP, proved as a patient have already ATTR positive type, what you are choose if your two medication in your pocket, you start by stabilizer or silence if both of them available in your pocket in your hospital. Newly comer diagnosis ATTR and both medication available in your institute. When you start stabilizer or silence?
When it's both, it's available, the patient preference. Some of patients, they will prefer the injection because the silencer, it's the injectional form, not tablets or oral therapy. and should be administered in the institution. We cannot give the patient syringe to be used at the home. This is very difficult for most of patients to going back and coming. For other stabilizer, it's used orally and can be dispensed for patient and take it at the home, and easy life for the patients. So it depends mainly on the patient, of both in my hands and regardless of the cost.
Nice, very nicely. Last point, our colleague Rola Osman, Dr. Morsi, thank you. Dr. Rajdi, thank you very much. Rola is a perfect nephrologist, and she always play in the field of amyloids, and that's why always they mention proteinuria without short diabetic history supposed to follow by infiltrative pathology, and is one of them is cardiac amyloid. Thanks, Rola. Anything important about SHAD score? Anybody want to say something? Thanks everybody. Thanks Dr. Rajdi, and thanks the company, and thank you very much. See you soon. Assalamu alaikum wa rahmatullah.